We are now ready to discuss neoplastic diseases as they pertain to dermatology. We are now ready to discuss neoplastic diseases as they pertain to dermatology. Certainly, neoplastic diseases can be divided into benign conditions such as nevi, seborrheic keratoses, and actinic keratoses, and frankly, malignant processes such as basal cell carcinoma, squamous cell carcinoma, and malignant melanoma. Nevi are benign tumors comprised of melanocytes. There are two main categories of nevi: common nevi, which are benign and unremarkable, and dysplastic nevi, or atypical nevi, which are often irregular in shape, irregular in pigmentation, or have atypical cytology under the microscope. Dysplastic nevi are possibly pre-neoplastic with an increased risk of development to melanoma, but this is not known with certainty. Benign nevi may be subdivided into three further categories: junctional nevi, specifically those with nests of melanocytes along the dermal-epidermal junction alone; compound nevi, with nests of melanocytes located both along the dermal-epidermal junction and within the dermis; and finally, intradermal nevi, with nests of melanocytes existing only within the dermis. Here is an example of a junctional nevus. Again, note the nests of melanocytes only along the dermal-epidermal junction. These lesions are typically macular and without substance. Compound nevi have nests of nevus cells both along the dermal-epidermal junction and within the dermis. These are typically raised pigmented lesions. Finally, intradermal nevi consist of nests of nevus cells only within the dermis, and they are typically less pigmented or apigmented. Dysplastic nevus or atypical nevus usually occurs sporadically. They may occasionally be associated with dysplastic nevus syndrome, an inherited disorder where a person has greater than 50 or even 100 atypical nevi. Atypical nevi are clinically noted due to their asymmetry, their irregular borders, their color changes or color variegations, their diameter being greater than 6 millimeters, and either evolution or changes in behavior or elevation. Here we see an example of a dysplastic nevus. In the inset, we see the clinical atypia as comprised by the ABCDs. In the photomicrograph, we notice architectural and cytologic atypia. Cytologic atypia is characterized by pleomorphism, hyperchromasia, and irregular nuclear contour. Architectural disorder is comprised of fibrosis, bridging between nests, and a chronic inflammatory infiltrate. Seborrheic keratoses are benign epidermal neoplasms that arise spontaneously in older individuals. Morphologically, they consist of round, white to tan to brown papules and small plaques with a stuck-on appearance. Under the microscope, seborrheic keratoses consist of acanthotic epidermis without any cytologic atypia, but with overlying hyperkeratosis and occasional pseudohorn cysts or collections of stratum corneum entrapped within the lesion. Actinic keratoses are the most common solar-induced neoplasm in mankind. They are associated with UV exposure. They consist of scaling lesions with slight surrounding erythema. They occur on sun-exposed areas and also show under the microscope hyperkeratosis, parakeratosis, and slight cellular atypia of the basal epidermal keratinocytes. A small number of actinic keratoses may go on to become squamous cell carcinoma. Estimates are anywhere from 1 in 1,000 to 1 in 10. The most common number is around 2 to 5% may progress to squamous cell carcinoma, but certainly this does not occur rapidly. It occurs over a long period of time in lesions that fail to resolve with treatment and continue to come back. Here is an example both clinically of an actinic keratosis and histologically an actinic keratosis. Note in the photomicrograph the slight disorganization of the keratinocytes within the epidermis, the slight nuclear atypia of the basal keratinocytes, and the overlying parakeratosis. Basal cell carcinoma is a frankly malignant skin process. It is associated with chronic but intermittent ultraviolet exposure. Morphologically, basal cell carcinoma consists of a pearly papular nodule, often with central ulceration, occurring on sun-exposed skin. Basal cell carcinoma is the most common cancer in all of mankind. It is locally aggressive, although very slow growing. It can be disfiguring if extensive growth occurs, but only rarely metastasizes. Here's an example of basal cell carcinoma under the microscope. Note the proliferation of basophilic cells arising from the basal epidermis and pushing down into the dermis. These cells resemble the stratum basale of normal skin, hence the name basal cell carcinoma. Squamous cell carcinoma is another intermediate form of non-melanoma skin cancer. It too is caused by ultraviolet exposure, but generally tends to be ultraviolet exposure of a chronic duration. Other causes of squamous cell carcinoma include arsenic exposure, chronic burns, chronic ulcerations, chronic inflammation, and immunosuppression. Squamous cell carcinoma is also locally aggressive, but does not usually metastasize, although its metastatic potential is greater than basal cell carcinoma. Basal cell carcinoma is more common than squamous cell carcinoma everywhere except the hands and the mucosa. In these two special areas, squamous cell carcinoma exceeds that of basal cell carcinoma. Clinically, squamous cell carcinoma consists of nodular and scaly lesions on sun-exposed skin. It is often ulcerated, but under the microscope one sees atypical squamous cells invading the dermis. Keratin pearls are often noted. In general, the cells have a more eosinophilic appearance than does basal cell carcinoma. Malignant melanoma is the most dangerous of all the skin cancers. It is associated with excessive sun exposure, particularly sun exposure at an early age. Intermittent sun exposure is also a risk factor. Melanoma in a first-degree relative increases the risk of malignant melanoma. Malignant melanoma may be associated with some other syndromes, such as dysplastic nevus syndrome or xeroderma pigmentosum. Commonly, malignant melanoma moves through two growth phases, a radial growth phase and a vertical growth phase. In the radial growth phase, the melanocytes grow out radially, and metastases at this juncture is rare. In the vertical growth phase, the melanoma begins to penetrate down into the dermis, and at this point it is thought that metastases is much more common. The single most important prognostic factor for malignant melanoma is depth of invasion. Malignant melanoma, like atypical nevi, is identified with the ABCDEs: asymmetry, borders irregular, color variation, diameter greater than 6 millimeters, and elevation or evolution, meaning changes in behavior. Under the microscope, malignant melanoma may appear differently depending on whether it is in the radial growth phase or the vertical growth phase. In all cases, you see a proliferation of markedly atypical nests of melanocytes, but in radial growth phase, pagetoid extent is more notable. Clinically, malignant melanoma is the most rapidly increasing cancer worldwide. The risk in the United States is currently about 1 in 65. The prognosis in melanoma is best determined by the depth of invasion, and this is the reason that transection should be avoided during biopsy. Metastases in melanoma is a harbinger of a poor outcome. The lymph nodes, lungs, and liver are the most common sites of metastases, and there is no truly effective chemotherapy at the present time. Early intervention, early surgical intervention, is key. This concludes our discussion of dermatopathology.